morning, everybody. Thank you to Action Duchenne for asking us to come down and just give you a little bit more feedback about where we are in terms of respiratory care. And I'm going to focus on the respiratory side of things, and Kadim's going to follow up with the cardiac side of things. So I just wanted to give you a little bit of a background as to where these guidelines came from. I know you've probably been told about or are aware of the DMD Care UK project, but this was a project that was launched in May 2019 because there was an awareness that we needed to update some of the standards of care that had been published in the international guidance in 2018. And that was in response to concerns from both patients and carers and clinicians that some of the guidance didn't feel applicable in the UK, and some areas were lacking in evidence, which meant that people weren't feeling comfortable about implementing it. And one of the real issues was that there was such a variability in care between different centres across the UK. The steering group was convened initially, and it was really important that we had a strong patient voice there so that we could set the right priorities for the different work streams. And following that, we identified the key areas to look at and develop specific working groups, and you can see that they're listed there, and that the respiratory guidance was about the third group to come into being. So just to give you a bit of background about what happens to the muscles in DMD, well, unfortunately, like all the other muscles, they will become weaker over time. But typically, we don't see problems until a bit later in the disease course, usually around the time of loss of ambulation. And I've just got some data here from one of the studies that McDonald published, looking at some of the data from the Synergy network, which is the American natural history study. And what this shows is the age of boys along the bottom, and this is a measure of lung function. So this is the FVC, so this is a measure you get from the spirometry testing, and it reflects how much oomph you've got, really, how much you can blow out of over time. And you can see that when boys start doing this when they're about 7, there is an improvement, and then things sort of stabilize, and then it gets a little bit more tricky, and the ability of those respiratory muscles to generate the same force reduces. And this is also showing about the benefits of the steroid use, because you can see that the steroid boys have got the pink bars, and that the steroids do seem to hold the respiratory muscle power for a little bit longer than those people who weren't treated with steroids. And this shows the same information, but it shows that going from a normal, if you like, FVC, which is calculated on age and size of your lungs, is from about 7 years, that gradually things become a little bit more tricky and those muscles decline, but the boys on the steroids, or the young men on the steroids, decline less quickly. But there are some other factors affecting your breathing. On the plus side, in a sense, the weakness of the respiratory muscles is relatively predictable. So that helps us work out when we need to look out for things and when it's going to happen. And it's much higher risk when you have developed some weakness in your trunk and weakness in your arm muscles. And that's an important clue for clinicians, because sometimes, it's hard for some of our young men and boys to do these blowing tests. And so we were looking for other things that would give us a clue as to when things might get difficult. And this is something called the Brooks score, which is when we ask boys to put their arms above their head. That would be full marks. Now, you can score it on an inverted so sometimes that gives you a 6 and sometimes that gives you a 1. But we know that it gets a little bit trickier over time. And it's when you get to about this point, when it's difficult to get your hands to your mouth, that it becomes more likely that you've got some weakness in your chest muscles. But we know that chest infection can cause deterioration in your breathing power. Poor nutrition's important, and swallowing difficulties. If you don't have good nutrition, you don't have the same reserve. And if your swallowing is not as good as it should be, you can get food going down the wrong way and into your lungs. And then the other big factor that makes things difficult is if you start to develop a significant curve in the spine, as you can see in this X-ray here. Instead of going straight down, if you follow the backbone, it's going around that way. That that makes it much harder to take a deep breath. So what happens when the respiratory muscles get weaker? Well, we go through sort of relatively, again, predictable stages where you have normal breathing to when you go to sleep and your breathing rate settles down as normal. You maybe aren't taking such a deep breath as you should. And typically that begins to happen during what we call REM sleep or rapid eye movement sleep. And you underbreathe during that sleep phase. And then as things get more weak, you can have problems with breathing throughout the whole sleep cycle and ultimately some weakness in the breathing muscles in the day. And this is a very old sleep study, apologies, and this shows what we do when we do the overnight oxygen level testing. And this is the oxygen level on this marker here, and this is the heart rate. And you can see that this young person's oxygen levels are pretty stable throughout the night, and that's normal, and we'd be happy with that. This is a sleep study of one of the older lads that I look after. This is a bit more complicated because you've got the oxygen levels here, and we've got the carbon dioxide here. This dotted line is what we think is kind of the normal level of the upper limit of normal of carbon dioxide. And the oxygenation level that we think would be happy with is probably around that line there. And so most of the night we can see that this young man is breathing quite effectively, his oxygen levels are good. But if you look, you can see that there are periods where it looks like there are dips. And this lad's beginning to get some difficulty when he goes into REM sleep. And if we look at his carbon dioxide levels through the night, they're just at times, he's retaining carbon dioxide, so he's not quite breathing as effectively as he should. And the other thing that we know is that if you get a chest infection, it can really make life harder. It can make those respiratory muscles less efficient, and it can tip you from one state into another. And the other problem that we see in the young men we're looking after is that they can develop problems with obstruction in their upper airway, sometimes because the muscles around the upper airway get weaker and a bit floppier, and sometimes because of the steroids, we've ended up making our young people a slightly different shape, and that can obstruct the airway. So we just need to be more cautious in those situations. The other thing that you might read about is what these measurements that we get on the lung function testing mean. And these things aren't absolute, and we'll come into that in a minute, but it would be really unusual to see problems with underbreathing if you've got an FVC of more than 50%, but it's not absolute, and so you have to be cautious because if you've got obstructive sleep apnea or you've got an infection, it might just mean that you tip into a different difficulty at night, and we call that sleep disordered breathing because it encompasses both the obstruction but also the weakness in the muscles. Once your FVC gets down to around 30%, then you are really at quite high risk of having problems with your breathing, and it may be that it affects your breathing in both the REM and the non-REM sleep. If you've got normal breathing effectively at night time, but your FVC is beginning to just change, you might be more vulnerable when you get an infection, and so that's a level where we know that you've got to be a little bit more careful. So why does measuring all this or thinking about this matter? Well, it matters because there are things that we can do to help. And we know that from other studies that by intervening early when you've got slightly weaker chest muscles and having strategies in place, that reduces the need for you to go to hospital, and it improves the time during which you'll recover from infection. So it's really important we look at things to reduce the risk of infection. So it's important to check that the swallow's safe, and it's important to maintain good nutrition because those things are important for infection. We also want to help with secretion clearance. So if your cough isn't as strong and you can't get that phlegm out from your chest, then we need to think about whether there are things that we can do to help. And some of you may be familiar with this device, which is called a cough assist machine or a mechanical insufflator, exsufflator. Don't make me say that again. And these things all help to improve the efficiency of the cough and allow you to clear the gunge out of your chest and respond more quickly to antibiotics. And if necessary, then of course we can look at supporting the breathing muscles. And we tend to do this initially using what we call non-invasive techniques. So these are using different, what they call interfaces. Sometimes it's just a sort of a nasal prong, sometimes it's a small mask over the nose, sometimes a slightly bigger mask over the nose and face. And that's something that the boys can wear and get used to and hopefully fall asleep with, that can make the breathing more efficient at night and minimize any of the symptoms you might be getting because you're not breathing properly. So when we came to thinking about the respiratory working group, we wanted to know what had been a problem for carers and families, and we went to the Duchenne UK survey, where 164 perspectives were recorded, sometimes from young people and adults, sometimes from their carers. And we had information from about 164, and on the plus side, 81% of them felt they were receiving the proper care. But I suppose slightly less positive, only about 50% were satisfied with the care they received. And some of the comments that came out were that people wanted clear explanations about why they were doing tests, what this equipment was for, and there was a lot of concern about the variability in practice. And this is a sort of graph looking at the summary of the feedback from families, and this is the respiratory one, and you can see that actually only 23% said that overall things were very poor, which is quite a bit better than, say, transition, but we'll come on to that another day. But we felt that because of this feedback, it was important that we looked at what guidance we were giving to family to make sure that people had access to the best possible care. And so that was the aim of our working group, to look at delivering the best respiratory care for everybody. And we wanted to provide some more recommendations about routine monitoring and management, but also particularly about acute emergency care, what to do if this young person ends up with a chest infection requiring hospital admission. And these are the documents we looked at. I'm not going to go into that for too much detail. But the process was that we developed the guidance, we then sent it out to the networks to make sure they were happy, we honed it. Poor Kathy, who's sitting in the fourth row there, did a lot of work trying to ensure that feedback was absorbed and incorporated. And then we got that guidance endorsed, and it was this guidance has been endorsed by the British Thoracic Society, and then we want to disseminate it through relevant clinical networks so those clinicians get to know, but we also want to make sure that parents and young people are more empowered to know what is needed by developing some more specific patient guides. So what does the new guidance cover? Well, it's a bit more about the routine monitoring, thinking about what should be done, when it should be done, and a bit more about the how it should be done. Who should be doing these tests? What tests should they be doing? And also particularly highlighting where that can be challenging, because there are some people that really struggle with these pulmonary function tests, and we want to make sure they still get the best possible care. This is just to show you a little bit more about what the FVC is. So these are curves that you get when people blow into the machines, and you can see that that's normal. Most of your puff comes out in the first second, but you continue to blow out until you've achieved your forced vital capacity. And this happens if you've got an obstructive airway disease like something like asthma, but when you've got restriction or reduction in your muscle weakness, you get that kind of pattern. So we've also, and I think one of the important things is put more detail in about what the criteria are where you should be referred on to get some more specialist advice. So we've stressed the importance of referral to a respiratory team who have expertise in DMD. And the importance of making sure there's a respiratory physio in that team who knows what to do. We've thought about the factors that should prompt referral, both in history and assessment, because it's not all about those pulmonary function tests. We've highlighted what symptoms you can get with sleep-disordered breathing and how it might present in different people, because sometimes those symptoms are quite subtle. And we've also highlighted those young people and adults that we think might be at higher risk. We have commented on the thresholds that should prompt referral, and I've alluded to those levels before. In particular, we've talked about the importance of an urgent referral. We don't want you to be on a waiting list for 8 months for a respiratory clinician. And we've talked a little bit about how we measure cough as well, to think about when a poor cough should trigger a referral. And we've stressed the need for that ongoing review. So once you've been referred to a respiratory team, once you've met those criteria, we don't want you to be discharged. We want you to stay on their books so they're keeping an eye on you and monitoring things going forward. In terms of the kind of other management, basically, it's really important that any intervention is tailored to a particular patient and their specific needs. We've stressed the importance of a low threshold for antibiotics. You've probably all come across the fact that there's a lot of pressure on GPs to reduce their antibiotic prescription, but we want to stress that in this cohort of our patients, it's important to have a low threshold. We've talked about vaccination advice. We've thought about how to assess sleep-disordered breathing, and it came through very strongly, but from the adult respiratory physicians on our working group, that they didn't want us to tell them what to do. I don't know why. But they wanted to be able to assess that young person themselves and decide what the best possible treatment was. And I think that's fair as long as they've got the expertise to do that. And that's why we want you in the right place. And we've provided some guidance on these things, as I've said before. I think that the emergency care was something that came out from the feedback as being important. And what we've stressed in the guidance is that people with DMD can rapidly deteriorate during an intercurrent infection, and that you may not show the expected signs. So when you're a junior doctor and you're receiving your training about how to detect somebody struggling with their breathing, you're told that they'll be lifting their shoulders up, they'll be pulling their muscles in. And of course, that's really tricky when you've got weak muscles. And so the sort of quiet, silent person is more worrying, and we want them to realize that. So we've highlighted that in the guidance. We've said that it's really important that people should listen to patients and think about their wishes. Ideally, we should have an opportunity to think about what they might be in advance rather than the A&E department, and to really stress how helpful an emergency care plan can be. The DMD in case of emergency app is tailored to sort of looking at this, but also highlighting to other clinicians what's important. And that app's being revised and is going to be relaunched at the beginning of 2024. Is that right, Kathy? Yeah. But also there is specific advice on how to construct a care plan available on the DMD Care website and from the project team should people not feel comfortable within their own neuromuscular teams to develop something like that. Again, we've stressed the importance of the emergency department teams making early contact with their nearest specialists, the importance of urgent assessment by a physio, and thinking about if you think somebody's struggling, consider supporting the breathing, even if it's temporary, ideally with a non-invasive technique, that picture I showed you with the masks, and moving a high-risk patient or somebody you're worried about early to a respiratory support unit. And there's a guidance suggesting that you shouldn't be doing tracheostomies on these young people without really thinking about it and doing it carefully. And thankfully, this is rarely needed if the other steps have been followed. We've also talked about the importance of not giving oxygen on its own. If you're blowing oxygen in the face of someone whose chest isn't moving, A, it's doing nothing, but B, it could be reducing the respiratory drive of those young people. So it's important to do that with thought and with monitoring. We've also picked up some of the other things that are important. Most of our young people are on steroids and at risk of adrenal suppression, and when they're unwell with chest infections, they need more steroid. So think about that. It's generally, in principle, it's better to give extra steroid than not to give extra steroid. If in doubt, give it. Think about the heart muscles. You're going to hear a bit more about that in a minute, because the heart and the lungs are pretty closely related. So one can have a really negative impact on the other. So it's really important that we think about that. And then there's this condition called fat embolus syndrome. I don't know if you've heard of it. It's pretty rare, thankfully, and usually we would think about it only being there in somebody who's had major trauma associated with fracture in their long bones. But we're beginning to see this happening in young people with DMD with really minor trauma. So I had a young man who was just putting his trousers on, standing up for his dad to put his trousers on, went down to his knees, didn't really experience much in the way of pain, but later started to develop shortness of breath, a bit of confusion, and his parents were very switched on. They knew what it was. Unfortunately, their emergency department team didn't, but they were able to get hold of us and get an urgent transfer to the critical care unit. So I don't want to worry you about that, it's just to be aware of it. So this is kind of what the guidance looks like. I'm not expecting you to study it, but again, Kathy did a fantastic job getting it into 2 pages of A4. This one is specifically for emergency care, and we think that would be nicely blown up and printed on the side of ED departments in another, maybe the general pediatric wards and places, or adult AMUs, places where people may not have that familiarity. And what we hope is that this will change practice. It will raise awareness of respiratory complications and the important aspects of care. It's going to be published in medical journals, and the guidance has been accepted a couple of weeks ago for publication in Thorax, and Kathy and the team will be presenting the information at conferences to reach those other people. We want to upskill clinical teams who don't have a lot of experience in DMD, maybe teams in the community, as I say, ED, other medical specialists, and we want to empower families to be able to access the recommended standards. And I think having a standard is really helpful because it allows us to benchmark what's happening, allows people to say, well, I live in X and I'm not getting these standards. And then their clinicians can go to their managers, and there's something there to help drive improvements. As I say, the guidelines have been endorsed and will be published shortly. We're working on our patient and parent family-friendly leaflet, and we're also linking in with the other work streams and the emergency app and the other working groups that are going forward. But it is important that we disseminate this through the community because, as ever, the people who need to know this don't know they need to know this. I just want to say these are the people who contributed to the working group. The bold people are the people from the various family support groups who were really critical in making sure that we kept this guidance focused in the right direction. And I want to just thank those working group members who pulled this together, the family focus group, the clinicians in the North Star, the steering committee, and the project team at Duchenne UK and Newcastle, and of course all those people who've been funding DMD care. And that, thankfully for you, is all I was going to say.